to allow for repolarization and avoid and to prevent a prolonged depolarization of the muscle. That's why acetylcholine is then later broken down into choline and acetate, and the choline is reused to form acetylcholine once again. Now, there are different proteins that we have learned about, and earlier we heard the speakers in seronegative myasthenia gravis, where we learned about antibodies to agrin and LRP4, and many of these proteins are also proteins that have been described involved in congenital myasthenia syndrome, as we're going to see. So the congenital myasthenic syndromes are a group of disorders, and they are genetic disorders. They are heterogeneous. They are very rare, but they are characterized by impaired neuromuscular transmission. And as you can see, a lot of the descriptions date back into the 80s and the 90s, where earlier clinical descriptions were reported. And now with whole exome sequencing, as we heard from many of the speakers, we are discovering more genes than we knew that were involved with congenital myasthenia syndrome. So this is a description of a 22-year-old man who you can see has fatigable ptosis that occurred after prolonged upward gaze. And this was described, I believe, in the late 1990s. So when do you suspect congenital myasthenia syndrome? So in general, it's a childhood onset. We have heard about adult onset or presentations in adulthood. Many of the adult patients that I have personally seen had childhood onset but were not diagnosed, either because the genetic diagnosis was not confirmed or because they were misdiagnosed. But in general, it is a fluctuating disease with fatigable weakness, can involve the ocular muscles, can involve the bulbar muscles, very common in the younger newborn period, and limb muscles in the limb girdle phenotypes. And as we said, commonly presenting early in childhood and in the newborn period. When we talk about clinical neurophysiology playing a role, you can either have a patient who you test and you never do see any results when you put them through EMG testing, but now we're learning about more results seen with single fiber EMG. But you do see a decremental EMG response in CMAPs with low frequency stimulation, and then we're going to talk about further diagnostics in addition. But these are just some of the clues to think about. If you do have a positive response to acetylcholinesterase inhibitors such as mestinon, and if you test for antibodies and they're negative, a seronegative myasthenic patient, especially in children, consider congenital myasthenic syndromes. If you have a seronegative myasthenic patient who you assume might be an immune-mediated myasthenia gravis, and you've put them on immunosuppressive agents, some of the patients you would inherit from other centers, and we did see some of the patients that were adults, and they've been on immune suppressants for many years before they're finally diagnosed with the congenital myasthenic syndromes. Another thing is that some of the phenotypes or the clinical features that patients do present with overlap with some of the presentations that we see in the congenital myopathies, whether because the gene is it's allelic to both diseases, but a lot of the features are similar, such as ptosis and facial weakness and respiratory compromise during illnesses. But one of the things to consider is that if you do biopsy these patients and you have very minimal pathological changes, that would be a consideration for congenital myasthenia syndrome. And I'm pointing out only a skeletal muscle biopsy because when we do suspect congenital myasthenia syndrome, usually a biopsy from the intercostal nerves would give you the clue. And there are very few centers, including Mayo Clinic, that would do this. We did not do the intercostal nerve biopsies at Ohio State. We usually sent the patients to Mayo if we needed that. And obviously a positive family history. And in cases of consanguinity, that would be very helpful. Clinical phenotypes vary by age of onset. I think it was, although it's a rare disease, but because it became such a big topic, and we usually get excited and we go through patterns of getting excited about certain diseases, it was still one of the panels that a lot of our geneticists would be sending if we are called for a newborn who has respiratory insufficiency and is immediately intubated and ventilated after birth. Usually go through, is it a type 0 spinal muscular atrophy, and then we go down the path of the congenital myasthenic syndromes. So in the neonatal presentation, the common referrals that you would hear about is if the child has respiratory insufficiency, some of these children are born, appear to be well, are sent home, come back with intermittent episodes of apnea and cyanosis. Another form of presentation, again, a common consultation that we received from the neonatal ICU, are the children with arthrogryposis multiplex. So these kids are born with multiple contractures. There's a long list of genetic diagnoses that could explain arthrogryposis multiplex. Sometimes we don't find an answer, but the congenital myasthenic syndromes are something that should be considered, and it's a result of reduced movement in utero. Other findings, feeding difficulties, a poor suck and swallow and cry. It's too close. Okay. Poor suck and cry, choking episodes, eyelitosis, facial and bulbar and generalized weakness. One other thing is stridor in infancy. It should be a distinguished feature for testing congenital myasthenia, especially if it's combined with reports of fatigable weakness. We usually hear the child is lazy. I personally do not believe there is such a thing as a lazy child. If a child is lazy, there's a good reason for that. So that's the neonatal period. A childhood presentation later on in young children would be the fatigability. So some of these kids appear to be well in the early childhood period, and as soon as they go through their growth spurts and certain milestones are expected of them, they'll be running through some of the challenges of keeping up with the peers, such as difficulty in running and climbing stairs. So motor milestones may be delayed as a result. Fluctuation in their weakness, including the ptosis and extraocular muscle involvement. Facial and bulbar weakness with nasal speech, difficulties in coughing, and a lot of these patients end up being hospitalized whenever they have a respiratory infection and have difficulties recovering from it and clearing their secretions. Spinal deformities can occur in some of these children, and muscle atrophy if it is a severe type of myasthenia gravis, that over time these patients will develop a muscle atrophy. Then we have the limb girdle presentation, and I've seen some of the patients that are misdiagnosed and over time where the limb girdle phenotype and the weakness is much more prominent, but it isn't until they manifest the ptosis and the facial weakness that someone starts considering it. Some of these patients do get misdiagnosed as a limb girdle phenotype or limb girdle muscular dystrophy until you search for some of the genes that are well known for limb girdle muscular dystrophy, and you don't find a gene, and that's when it's considered. But these are three of the most common clinical presentations that if you were to see a patient with this, and you've gone through the more common diagnoses, and all of them have been excluded, consider congenital myasthenia syndrome. Even if it's an adult, there's a good chance that if you look into the history, their past history may provide some clues and hints with difficulties in stairs or keeping up with their peers at school. So these are some of the proteins. This is from the Oxford group, where they do have a great database for the genes that are commonly involved in congenital myasthenia in England. And when you look at the epidemiology, the reported cases and what's more common varies depending on where the patients are from. But this summarizes the most recent proteins that we do know of. And I can tell you that when I was preparing for this, it was very surprising to me that I had missed so many of these genes that have been reported in the last couple of years, and if you're not keeping up with the literature and having a lot of patients that come into your clinic, I think it's something that we're learning every day about new genes, and whole exome sequencing has definitely contributed to the discovery of many of these genes. The classification in general, for the most part, is based on the location of the protein. So we have presynaptic defects. The presynaptic defects can be characterized based on which part of the presynaptic membrane is affected in terms of function. So you have some proteins or genetic defects that affect axonal transport. Others that affect the synthesis and the recycling of acetylcholine, and then the packaging and exocytosis of the vesicles that carry the acetylcholine into the synaptic cleft. Now, in the synaptic defects, the COL-Q is what I had mentioned earlier to hear from some of my colleagues that it is the most common here in Saudi Arabia. And then the newer proteins, some of the newer proteins are the basal lamina proteins that have been recently described. Postsynaptic defects, obviously the acetylcholine receptor deficiency, a primary deficiency, has been described and very well characterized in the literature. Then you have the kinetic abnormalities of the acetylcholine receptors, and it could be with acetylcholine receptor deficiency or not. Earlier, one of our speakers presented a beautiful scheme of the signaling pathway of the agrin LRP4 MuSK signaling pathway. So any of these proteins could be defected and result in impairment of the signaling pathway. Then you have the rhabsin and DOX7 and the sodium channel 4A. One of the things that I found interesting is that in some of the literature reviews, and from speaking to some of the colleagues, including Dr. Aisha mentioned that she had 2 siblings with DOX7, and I think it's just a matter of if we do have patients and we do have cases, reporting these cases in the literature so that if you read some of the reviews, they'll describe, oh, only 4 or 5 patients have been described. I'm guilty of this. We had a couple of patients that we never reported with novel mutations and different phenotypes, but we do know that it is expanding in terms of the phenotype. The final category that is a fascinating category, and the glycosylation defects in general, and the congenital muscular dystrophies being near to my heart, is always something that we talk about with younger children, especially in the first year of life, newborns and in infancy. But there are new congenital myasthenic syndromes that are reported due to abnormal glycosylation. The clinical variability is something that within the same gene, within the same family, you might see that there is clinical variability, but this is a very busy table, and I don't intend on going through all of it, but my goal is to show you that with each gene, there are different CMS subtypes, and the clinical features could guide you, but the reality is there's so much variability within the same genetic defect that sometimes, unless you do the genetic panel for CMS, it's going to be difficult to be certain, confident that of going through one gene after another. But the reason I want to highlight this table is that there are some of the congenital myasthenic syndromes where you can offer acetylcholinesterase inhibitors, but there are some that you have to be really careful with where there is deterioration, you might get a negative response, and I'm highlighting the ones that are in red, which is the acetylcholine receptor, the CoQ, you may have deterioration, you may not get any response or any improvement, and then the DOX7 patients. And again, this is for most of the patients, but there's always exceptions to some of the situations as we see in the clinical setting. Clinical variability, according to genetic etiology, apneas are commonly seen in rhabsin patients. We did have a young girl who was part of a clinical trial for the 3,4-DAP by Catalyst, in which growing up, apneas were one of the more common features that she had. Once she reached the age of 5 and 6, she was having less apneas, but it was frightening enough that they ended up getting a tracheostomy. And then no response to treatment with acetylcholinesterase inhibitors, consider CoQ, again, the demographics and where the patients are. Pes cavus and hammertoes, consider one of the newer genes that have been described, the SYT2. If the patient has contractures, rhabsin is possible. I do know some patients that, as I described, that do have rhabsin but don't have contractures. And then if there's autosomal dominant family history, there are some genes that have been described in the dominant matter. So diagnostics, I think clinical history is by far the most important. I think we've heard about in general, most of the neuromuscular junction disorders, a careful clinical history is what kind of guides you to, is this fatigable weakness, is it fluctuating, to distinguish and make you think of down that localization pathway. Some of the patients can have elevated CK, but for the most part, the CK is normal. Antibodies are generally negative. I did see that there was one case report where a congenital myasthenic patient also had autoimmune myasthenia gravis, but that is likely not something that would be, well, it would be difficult to link it, but that was the one case report that I found. Electrophysiology, I think of the 4 patients that we had, we only had, at least the ones that I have seen and experienced, and I'm curious to hear from others, I think there was only one patient that we actually did have an abnormal EMG study. In some of the case reports of the MuSK myasthenic patients, we also did see that as reported as it was negative. Now, was it negative because the extensive testing was not done and single fiber was not done, or is it that there was no response at the time of testing? So generally, a decremental EMG response is seen with low frequency, about 2 to 3 hertz stimulation. In some of the patients, if you don't get a response, a decremental response from the 2 to 3 hertz, you can go ahead from a rested non-weak muscle, then you can try a decremental response after 5 to 10 minutes of stimulation with 10 hertz. Single fiber EMG, if available, and for those who are child neurologists and don't sedate the patients, we did not, for a long time, sedate patients. I initially trained in Toronto. We did not sedate patients there. At Nationwide Children's, sedation was added later on, but it can be challenging to do single fiber EMG in young children. Response to acetylcholinesterase inhibitors, as Dr. Demenchi mentioned, we do not do the tensilon test, but you can attempt to do acetylcholinesterase orally and being very careful. The key thing is if you're testing it, you do have to identify an endpoint. What are you measuring? Is it ptosis? Is it tongue weakness? Is it an EMG finding, so that you have something to start with a baseline and then assess for a response? Morphologic studies, as I mentioned, skeletal muscles usually don't yield that much findings, but in some of the dystroglycan CMS-related changes, you may see dystrophic changes. And then we talked about looking at neuromuscular junction through intercostal nerve muscle biopsies. Now, this is definitely not relevant to where we are right here, but I think this is something that I put up that we commonly see. If you are from an area where you have patients of diverse backgrounds, you do want to consider the different genes, and I think it would be really interesting, and I'm curious to see if there is a cohort of patients that can be put together for the demographics here in Saudi Arabia, whether it's the different regions or different tribes, to consider when approaching these patients. I think it's a luxury that we have whole exome sequencing, but the turnaround time and the cost is something that always becomes a challenge. And if you can send a congenital myasthenic syndrome panel, knowing what target genes you have in mind, I think it would be much more cost-effective and efficient in terms of a turnaround time. Diagnostic challenges, it's just like many of the neuromuscular disorders, we do have diagnostic delays and diagnostic dilemmas in the pediatric patient population, but most of the challenges in the patients, in the adults, if it seems like the onset was later in adulthood, or if you can't get a reliable history of onset in childhood period. If you don't have a family history, obviously that makes it more challenging. If the symptoms are episodic, so that when you're seeing the patient, you're actually not able to elicit any fatigable weakness. If there's no ocular muscle involvement, or if there's no cranial involvement, there's no facial, no bulbar involvement. In the decrement, as I mentioned, may not be present in all the muscles or intermittently present. Usually what we did is if you can't find it in the traps, if you can't find it in other muscles, then you eventually go to the facial muscle, which is very unpleasant in children that are unsedated. Many of the patients had been misdiagnosed as congenital myopathies. We did have a patient that was diagnosed as a muscular dystrophy before she was finally diagnosed in adulthood. By the time she was pretty disabled in her 40s. Some patients are misdiagnosed as seronegative myasthenia gravis and end up on immune suppressive agents. And then some of the patients could be misdiagnosed as metabolic myopathies. Now, the Oxford group has a good number of patients that, based on the features that they have described and observed to be the more common features, they came up with this proposed algorithm so that you can target genetic screening. And it's a great approach for clinicians who don't have the luxury to access whole exome sequencing or don't have the budget to cover such large genetic panels where you have to go through one after another, or if you want to go through targeted genetic testing. Now, I can say that when I was going through the algorithm, some of the observations I noted, for example, if you go down the path of ophthalmoplegia and it's no, and it takes you down if it's predominant limb weakness or not, I see some of the genes that we actually saw patients with different features. So they include MuSK under the no ophthalmoplegia. Our MuSK patient actually did have ophthalmoplegia. So again, I think that a lot of these diagnostic approaches are great as a guideline, but at the end of the day, I think because this is ever expanding, you might be describing a new clinical phenotype. So I would not, especially in this category of rare diseases, I would encourage making sure that not fitting the patient into a box, but actually being curious about their features and that they might be part of the new phenotypes to describe.
2 minutes, please.
So we're coming down into the last few slides, but pharmacotherapy, acetylcholinesterase inhibitors or mestinon are commonly used, and most of the congenital myasthenic syndromes do respond to them. There are some here that are listed where you do want to avoid the cholinesterase inhibitors, especially in the COL-Q because of the negative effects. But some of the other congenital myasthenic, if they don't respond to mestinon, 3,4-DAP, which for the longest time was very difficult to access, and we had to go to compounding pharmacies to actually get the drug. Up until Catalyst licensed 3,4-DAP and is now available in clinical trial in the US. And I think they completed the Lambert-Eaton, but I believe they're still recruiting for the congenital myasthenia. This is another algorithm of if you have suspected congenital myasthenia syndrome and you kind of go down the path, if you don't have the genetic defect yet and you want to start the treatment, this is another path as to what are the treatments available and what they would recommend. And as you can see, avoid mestinon or pyridostigmine in the DOX7, COL-Q, and the slow channel syndromes. And then the other congenital myasthenics, you can try mestinon if there's no improvement or minimal improvement. And some of these patients do improve, but it might take time for them to actually show a response. And some patients might respond, and after months, they might come back and say, I don't feel like it's helping me or working anymore. And that's where you might consider adding 3,4-DAP. Salbutamol or atenolol is another drug, and we've used atenolol in our myasthenic patients in our DOX7, and they seem to have an excellent response to atenolol with very minimal side effects. Clinical studies and trials, and this is going to be the last slide. There was an albuterol study that was completed. I couldn't find the results published, but that was one study looking at the efficacy in some of the congenital myasthenic syndromes. The amifampridine is the clinical trial that is recruiting in North America and for specific congenital myasthenic genotypes. And viral vector mediated, so because I talked about gene therapy and I thought people are going to be disappointed that I'm not talking about gene therapy in congenital myasthenia, but there have been a few studies in animal models, and one of Andy Engel's former fellows, who's now in Japan, did publish in 2009 on COL-Q AAV using it and showing some improvement. There hasn't been a follow-up in terms of clinical trials, and that was the only clinical trial. But I think we can all acknowledge that it's rare. You don't have natural history studies. There's so much variability in phenotype, which makes clinical trials in these patients quite challenging. I'm sorry I had to go through this really quick. It was a 20-minute talk, and I'm sure everyone's wanting to get through the next presentation and get home, so I thank you for your time.
Thanks, Dr. Zaidi, for your presentation. And last presentation will be for talking about thymectomy for myasthenia gravis will be presented by Dr. Majid Al-Abdali. Dr. Al-Abdali is a neurologist, neuromuscular disorders, and EMG specialist at King Abdullah Hospital in Al-Khobar and Dammam.
Assalamu alaikum. Last slide. This is the previous one. Okay, sorry for this. I would like to thank Dr. Kopler and Dr. Aisha for kind invitation, and all of you for attending. It's difficult to present last lecture. So today, inshallah, I will talk about thymectomy in myasthenia and why. Because nowadays become more evidence to refer patient for thymectomy in a special situation. Brief about myasthenia, why we care about thymus, because we know 70% of the patient of myasthenia have lymphoid follicular hyperplasia and 10% have lymphoma. And it started the thymectomy in early 40s by an American surgeon called Alfred Blalock, when he reported improvement about 50% of his patients, 3 out of 6, with non-thymomatous myasthenia after thymectomy. And all observational studies support good outcome and clinical improvement after, especially if you diagnose patient early on with thymic hyperplasia after thymectomy. So why thymectomy? And if the patient asks why you refer me to a surgeon while you give me medication, because we know thymectomy may reduce severity of myasthenia by reducing the immune activity. Also indirectly reduce the medication, and that will lead to decrease the adverse effect, and some patients will go to a complete remission. We are not surgeon, thoracic surgeon, but Dr. Jassim asked very the question, what's the difference between certain approach for trans-cervical or robotic? So I'm going to talk about the difference between there is evidence which is best, or there is equal, or there is no difference. So we have 4 approaches. We have trans-cervical, trans-sternal, and combined, and videoscopic and robotic. And the commonly used is extended trans-sternal approach, and it's being commonly used for most of the studies. And the good about, again, why thymectomy? Because we have less mortality rate. It's even less than 1%. And most common complication, which is rare, acute respiratory failure after myasthenia crisis, around 6%, and infection, 11%, and rarely recurrent laryngeal or phrenic nerve injury. This is a bit old. I'm going to show you the new American Academy recommendation. But this was a literature review of 21 observation study done in late 90s. And they conclude that patients who underwent thymectomy, they are twice more likely to have medication-free or complete remission, and nearly twice more likely to improve. And in patients with severe myasthenia, 50% of them tend to have better outcome, especially if they are young women. So why we need to study thymectomy? Because before the New England Journal, the thymectomy study, there were no study matched patients successfully for all confusion factor. Plus, there is no standard technique to go for thymectomy. So they conclude the benefit of thymectomy cannot be established without randomized clinical trial. So this study came out, and I'm sure everybody's aware of it. Why they did it? Because there is lack of randomized trial on benefit of thymectomy on myasthenic patient. And the hypothesis also behind it, they want to see, or they want to prove that the sternal thymectomy combined with low dose or standard dose of prednisone protocol is better or superior to prednisone alone, and with respect to less myasthenic weakness and lowering the total prednisone dose and enhancing the quality of life. I'm going to go, Dr. Mazen also mentioned the slide, but I'm going to go a bit detailed. It's multicentral and blinded, randomized trial. They include patient diagnosed in 3 years, and later on they include in 5 years with extension study, and the age from 18 to 60, then they extend up to 65, and the seropositive more than 1, the titer. There's also, they include patient from 0.5 to 0.99, but should be combined with both positive tonsilline test or plus abnormal single fiber or repetitive nerve stimulation. And they choose mild to moderate generalized myasthenia with a score of MGFA 2 to 4. And they put the primary and secondary outcome. And we know the primary, they want to see the time-weighted average QMG score over 3 years, and time-weighted average of required of prednisone dose also over 3 years. And the secondary outcome, they want to measure the activity of myasthenia daily living scales, plus the MMS, which is a minimum manifestation state, and day of hospitalization and adverse effect, and use of non-steroid like Plex or IVIG. There were 126 participants. 2/3 of them were ladies, and 2/3 of them were on steroid, and the median age was 32. almost all of the patients had mild and moderate generalized myasthenia, and the median duration of randomization was 1 year. And both groups were matched regarding to demographic and use of pardostigmine and IVIG plex. So the result, it was a significant study. So the estimate difference was around 2.85 in average QMG score in clinical improvement, and the reduce of prednisone, the difference between the two groups favored the thymectomy group by 22 milligram, which both were clinically significant as a primary outcome. When it comes to secondary outcome, even though up to 67 of the patient achieved the MMS, MMS scale, plus versus in prednisone group mainly 47, and also the hospitalization requirement of exacerbation, their favor to thymectomy group. Though the subgroup analyses were not conclusive, but all the parameters were favored to thymectomy group with regards to female and patient younger or older. I think this is a mistake, it's younger than 40, and patient with exposure to steroid also favored to thymectomy group. So they conclude that transsternal thymectomy in patient, in two quote, preferably young women with non-thymomatous acetylcholine receptor generalized myasthenia, mild to moderate, and diagnosed recently, the result will be better symptoms control, reduction in steroid, hence it will less the side effect also, and less frequency of the exacerbation, and which lead to less requirement of plasma exchange and IVIG. This is just we explained a while. The demographic group, this is taken from the origin study. As you can see, the prednisone group and thymectomy group, and you can see the reduction in thymectomy group plus prednisone in QMGS and in prednisone dose. And also this primary outcome, I will not go through it, we just mentioned it. And this just recently published in January, as Dr. Mazen said, the 2-year extension of myasthenia thymectomy trial, which also strengthened all the studies. So they follow the patient up to 60 months at 5 years, and 60-month visit then at 5 years, and still the QMGS score was significantly lower in the thymectomy group, and also the alternative prednisone dose was also significant in thymectomy plus prednisone group. The proportion of patients also who achieved MMS were 30% higher in thymectomy group, and also all other secondary outcome measures favored the thymectomy group. And this is the extension study published in Lancet Neurology. And this is just to show the difference between, it's just continuity of 3 and 5 years in QMG score and as a primary and secondary outcome. So if you work in tertiary hospital and have more than thoracic surgeon, and each one train in or prefer different technique when to refer as a neurologist or as a neuromuscular specialist. And this is also have been looked up. This is last year publication. They compare the thoracoscopic versus transsternal approach. They collect more than 80. It's not a prospective, was a retrospective study. They collected around 98 patients, and they found blood loss as well as ICU and hospital stay were significantly less in thoracoscopic group. 9 out of 10 did not have any post-operative complication, and no hospital mortality, no in-hospital mortality. Thymoma, of course, they were more frequent in transsternal, I think because they collect more tissue, and more than thoracoscopic group. And at 3 years, and this is what we are concerned about, and this is what support the trials, the New England trials. A third of the patients have pharmacological remission, or complete pharmacological remission in, complete remission, third of them, and they reach to complete pharmacological remission in 3 to 6 months. So all these, both group. So this is give us almost there is no difference in thoracoscopic and versus transsternal. What about sternotomy versus video assistant thoracoscope thymectomy? And this is meta-analysis also published in 2016. They looked more than 2,000 patients, 984 did video assistant, and more than 1,260 transdermal. And they conclude there is no changes, no obvious difference in post-complication, post-thymectomy complication, or myasthenia crisis, wound infection, or resected thymus weight, and chronic. Both of them reach the complete. There is no difference in reaching the complete remission in 2 arms. What about robotic thymectomy? Again, this has been looked up. This retrospective study in collecting 125 patients, and the median post-operative hospitalization was 3 days, which is good for the surgeon or even for administration. And less than 1% developed pneumonia and pleural effusion, and at 3-year probability in complete remission was 17%, and plus pharmacological remission was 28, and they favor the younger age. What about robotic versus thoracoscopic thymectomy? Also, this has been looked up. So this is for you, Dr. Jassim, the refer patient to robotic. Also, there is no significant difference, but the thymic hyperplasia more in robotic they found, whereas 68 more, in thoracoscopic. Thymoma, 11 patient in robotic, and 6 in thoracoscopic group. The mean surgery time, and this is the significant for surgeon, more in robotic. So this is a problem in OR time. So some surgeons prefer to do thoracoscopic thymectomy or video-assisted thymectomy. And the mortality in 30 days were 0. And both of them, up to 40% of them reach the complete remission. What about anti-musk? Unfortunately, no study proved that the benefit of patients with anti-musk, and this is just recent publication. They look up actually the design of the study where evaluated rituximab and anti-musk myasthenic patient, but they did a post hoc analysis from retrospective study, and they compare after analysis and everything. They found there is no difference, and there is no association with greater likelihood favorable clinical outcome between those who did thymectomy and those who didn't. So this analysis did not detect favorable clinical outcome. What about elderly thymectomy in older age? Also, this have been looked, and more than 27 years, more than 50 patients, age of more than 50, and they conclude underwent thymectomy, around 34 patients, and 105 with no thymectomy. And actually, it's interesting that they found the patients who underwent thymectomy, they tend to do better with good tolerability. What about in the international consensus guideline? As Dr. Mazen said, it will be, inshallah, I think next year it will be reviewed, and we'll have more updated version. But in general, thymectomy in non-thymoma patient, it's an option to patients who you want to avoid or minimize the duration of immunotherapy, or patients who fail immunotherapy, or patients who have unfavorable side effects, and should be performed in safe clinical setting with less invasive technique like video assistant or robotic. And it may be considered if patient with generalized myasthenia with seronegative, if only fail response to adequate immunosuppressive therapy, or you want to avoid or minimize the intolerable side effect of immunotherapy. And current, as we mentioned, current evidence does not support indication of anti-musk patient or LRP4. And with the exception, very, very rare exception, all patients with thymoma should undergo surgery to remove the tumor. And in elderly people with multi or morbid patients with thymoma, they recommend to go palliative radiation. in appropriate clinical setting. And in patients with small thymoma, they recommend to follow patient unless it's growing large or patient become more symptomatic, then you should refer the patient to the surgeon. Children, Dr. Ahmed also asked this question, when to do thymectomy. It's unclear, but should be considered, especially with generalized stalking receptor antibody positive, generalized myasthenia, if response to either pyridostigmine or immune suppressive therapy is unsatisfactory, or there is or to avoid a potential complication of immune therapy. So patient underwent thymectomy. What's the complication or risk for post-thymectomy complication? And there is a study done, a retrospective study in 2015. They mentioned that delayed intubation, it's a major risk for myasthenia crisis. And third of the patient, third of the patient, the incidence up to 6%, and third of the patient can experience a second episode if they have the first. And also, this is a new, another group, they look for the risk factor, vascular and anesthesia physician, and they found higher QMG score can lead to post-thymectomy myasthenia crisis. Also, patient would have bulbar symptoms before the procedure or decrease the forced vital capacity, previous history of myasthenia crisis, the presence of thymoma, and of course, large operative, preoperative pyridostigmine dose or myasthenion dose, and high titer of antibody, or intraoperative blood loss, all are a potential or high risk factor to develop myasthenia crisis. And for this, I think I finished. Thank you so much for being here. I appreciate it.